Hello, and welcome to the Alabama Public Health Training Network. Adequate nutrition and good hydration make up the foundational pillars of well-being and good health, yet both are major challenges for many patients in home care and long-term care settings. Today we will discuss the importance of hydration and good nutrition and review the strategies to improve patient outcomes and prevent unnecessary re-hospitalizations. Thank you for joining us for today's program, How Hydration and Good Nutrition Can Help Home Care and Long-Term Care Patients. If you have questions about anything that's discussed today, please call or email during the broadcast. The phone number and email address are on your screen now and will appear later in the program. Also, the handout, sign-in sheets, and evaluations are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for the nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While the content may continue to be relevant, CME Credit will be awarded for 1 year for nurses expiring on April 30th, 2016, and 2 years for social workers expiring on April 30th, 2017. I'm Jacqueline Giddens. I'm a nurse with the Bureau of Home and Community Services, and with me today is Julia Sosa, Director of the Office of Minority Health, and welcome to everyone. Thank you, Julia.
Thank you. It's a pleasure for me to be here to talk about how hydration and good nutrition can help the home care and long-term care patient. When we came up with the topic and the title of the conversation, I didn't want it to sound dehydration and malnutrition that are two, not two good signs of nutrition, especially in any individual, but especially in the home health care patient. And so first I'm going to talk about issues of malnutrition, which is not proper nutrition, and then we'll address hydration. But I know that a lot of you want to know, sometimes you want to know the specific definition of what malnutrition is, or what poor nutrition is, and as defined by several references, malnutrition is due to inadequate or unbalanced intakes of nutrients, or their impaired assimilation or utilization, or it is the unhealthy condition that results from not eating enough food or not eating enough healthy food, or poor nutrition. Some of you might think that a malnourished person probably will look cachectic, will look thin, will look pale, but also a severely obese person can be malnourished. So another definition for malnutrition is inadequate nutrition caused by the lack of a balanced diet or by disorders of the digestive system in which nutrients from fruits cannot be absorbed properly. And so when I look at patients or I'm addressing malnutrition, I always think, what are the factors that are affecting that individual to not have proper nutrition? And sometimes we tend to look at labs, we look at symptoms, we look at complaints, but we tend to forget our digestive system. So that's one thing that as you home health staff or other staff that is listening to our webcast today, I want you to be in tune of different factors that you can look into when you are identifying malnutrition in an individual, or if that individual patient is not properly nourished. Mainly, I will talk of the adult population. This doesn't mean that it doesn't happen on the pediatric population, but the recommendations, the signs, symptoms, I'm going to mainly address adults, but from time to time I might address children, because I know that we have pediatric patients, correct? Okay, so when you look at what are some things that you need to identify in an adult individual with malnutrition, one of the first things is insufficient energy intake. What I mean by that is your caloric intake. How much are they eating? How much are they drinking? And when you do the assessment and if you're dealing with a home-based patient, how much have they eaten? How many meals do they eat a day? How many snacks? And not only how much are they eating, but what are they eating? Because again, as you're addressing proper nutrition, you have to, and we'll talk a little bit during my presentation, at what are some of the factors that you need to keep in mind when you're addressing malnutrition. So then one of the most common things is weight loss. What has been the individual's weight loss, the individual weight as you're seeing the patient or when you start seeing the patient, what was the usual body weight of that person, has there been a weight gain all of a sudden, because sometimes they will address inflammation, can mask malnutrition. Also, based on the conditions that the individual had, how long ago, has the weight been steady? Has the weight loss been in the past 3 to 6 months? Has it been in 10 days or 5 days? Also muscle mass, but how can you address muscle mass in a home-based patient? Unless you have tricep skin fold or you have all these different gadgets that you can have in an inpatient institution. But if you're at home, you could, as a nurse or an aide, or even if you have dietitians visiting the patient, you can address muscle mass. Sometimes you can take measurements and just see, if that's going on. Again, another measurement is loss of subcutaneous fat, but how are you going to measure that at home, right? So some of the recommendations I'm giving, yes, they're applicable for the home-based patient, but also they're used in a clinic setting. So other things that are recommended to identify malnutrition, again, I mentioned how fluid accumulation sometimes can mask weight loss. So in an individual that is malnourished, they can start having edema. And I know that when we talk about hydration, that will make sense. But the edema can be a side effect of what's going on in the system. And so it's always good to look at the patient and see if there's any swelling and any edema, and to play that into a factor if you're addressing weight, if that's a way that you're trying to look at nutrition in a home-based patient. And then one as simple as diminished functional status, in the sense, can the patient get up easily? Is the patient fatigued? Is the patient able to stay awake? Sometimes family members say, so I'm glad my husband, my daughter, whoever is sick, I'm glad that they're resting, that they're sleeping a lot. Well, that in itself could be a sign of malnutrition if there's a lot of fatigue and not enough calories, that the person is, might be sleeping too much. So that's another thing that could be as simple as just questions of asking, is that individual being able to sit and do their daily functions within their condition? Or are they more lethargic? Are they complaining more? Are they able, and sometimes the person can be as weak and malnourished that they don't even have the energy to feed themselves. So that's another way that you can also look at an individual without looking at lab values and charts and other parameters. So what are some things if you are going to a home and you are questioning, I know that when you invited me to come and give this presentation, you said, Julia, how can we do so that the person cannot be admitted or, decrease visits to the emergency room or even to the physician? So, things that you have to keep in mind is the diagnosis of the person. How long have they had that? Is this something, their behaviors, their lack of appetite, their lack of stamina, is that how the person is? Or has those changes happened all of a sudden? Because one of the things is, you might have a depressed individual that may be the lack of eating, the lack of, doing daily things. It's not because of a diagnosis, it's just because flat out they don't feel like doing it. So, doing a good history, if you're questioning proper nutrition, that would be one of the things to do. clinical signs, again, in a home setting would be the issues, something as simple, have you used the bathroom? Have you had a bowel movement? How many times a day? Have you eaten? Do you have any nausea and vomiting? Do you have any diarrhea? Those are things that you can look in the patient and decide just the turgor of their skin just by touching their arms or their skin, just the grip of the handshake. I know I'm a very touchy person, and sometimes when I have done home visits or even in a clinic setting, I always shake the hand of the patient even if they have an infection. And, of course, I'm wearing gloves to see their grip. And just with the handshake, you can tell a lot if a person is eating or not. In regards to anthropometric data at home, it would be more the issue of weighing them. It would be more if you have a measuring tape, as per se. Some people might say, I don't think I have lost weight, but my clothes feel looser. So you can measure, their arms, their waist, their thighs. And then again, lab data. If they have gone to the doctor, they have a doctor's visit, and I know you guys get copies of that to follow up and see how the patient is doing. Different, and I'll talk a little bit more later about the different lab values and what it means. But if you have current or within a month lab, you can see different parameters that can show that a person is having some nutrition issue and that needs to be replenished. And then, of course, the most simple one, and later in our presentation, we're going to do a skit so that you can kind of know what questions to ask. Ideally, if you had a dietitian, you would use a dietitian. But I know that in home health, we do not. In public health, we don't have a dietitian. But it's something as simple as, and I talked about it as I started, what have you been eating? Doing a diet history, as simple, ideally you want to have more than just one day. But if a family member says, that, and I'll put it, usually you take care of your mother or father. So my mother has been irritable. My mother has been sleeping a lot. My mother, has had a lot of nausea. And then I noticed that my mother is having problems swallowing, and she hasn't been eating much, but she's been able to drink, but she can drink water and nothing else. So just in the issue of the foods that individual is taking, it can help and to see, what areas do you need to focus in regards to nutrition. And then again, you'll hear me reflect a lot on functional assessment, because at a home, not in a clinic setting, but in a home-based setting, and this is what we're catering this training today, is again something as simple as a handshake. If you help the person sit down, are they lethargic, or they can help you, or do you feel like you're literally moving dead weight? And so just by those three things, you can tell that that individual is not getting enough nourishment. So, and then in regards to the previous slides, we're talking in regards to symptoms of characteristics of malnutrition. So now I'm going to talk a little bit about symptoms of malnutrition, and of course, keeping in mind the diagnosis of the person is, how do you know that the weight loss is not because, and I'll give an example for like on a dialysis patient, and I know you want me to address people on dialysis or people with chronic renal disease. In patients that have not gone into, that are not quite receiving dialysis, but what happened? My microphone. Oh, okay, sorry. I get distracted pretty easily, I'm sorry. But anyway, going back to the dialysis patient, somebody that is not quite being dialyzed, the unexplained weight loss or weight gain could be misconstrued as malnutrition. And then I'm going to go with that patient with chronic kidney condition, and or like having kidney failure. One of the ways, besides their lab values, that you can tell that they're going to end up on dialysis is because they cannot excrete their body fluid. They cannot excrete urine, and they have other issues. And so if you're at say it's a new nurse, right? And they go to the home and it's a person that is on dialysis and they saw them Monday a week ago and then they come back the day or the day off or the day after they had dialysis, they're going to have lost a lot of fluid weight, right? So if you just base your symptom of malnutrition on that weight loss, you can be misdiagnosing somebody. So I went into all that explanation to say that yes, weight is a good parameter, but you also have to look at the period of time that that individual has had that weight loss. And again, also it could be weight gain. And I know that I have already mentioned that in regards to edema, if a person is having fluid retention, people that are taking steroids, people that are on chemotherapy, people that are in taking radiation, their body reaction to the treatment will be to retain fluid. Again, that also can be a sign of malnutrition. One as simple as feeling tired. I don't know about you guys, but if you have gone through a day without not eating much, one of the symptoms that you will feel is that I'm feeling fatigued. And if you're a very busy person and you don't realize that you haven't eaten much, that again, it's another sign that healthcare nurse or aide can look and say, oh, Miss Sosa, have you felt tired today, or how long have you had this symptom of tiredness? And then the next bullet, taking a long time to recover from infections. I constantly hear, I have had this infection and I'm on my 3rd or 4th round of antibiotics. How many times do you take the time to ask that person, well, what are you eating? Or what are your lab values? Why? What are your symptoms? Because sometimes it's not necessarily the medications that the person is getting, but actually there is an undercover malnutrition that is preventing from the body to heal that infection. And what we do as healthcare providers, oh, let me change your medication, let me try this, when you really could just do a good assessment and do some lab values that I'll talk about in a little bit, and that you can see, okay, this infection that prolonged is not because I'm not treating it like I'm supposed to, but it's because this individual is having issues with malnutrition or nutrient deficiency. And on top of that, usually it comes neck to neck, is the delay of wound healing. A lot of patients that are bedbound, again, they're not as active, and they do not, circulation is an issue. And so, of course, if they are not moved or rotated or hydrated enough, then the issue, I call it the monster of the skin, where the skin breakdown starts. And so then, the skin breakdown is addressed, it's measured, it's look how deep it is, what stage it is. But do we take the time to think, okay, what is this person eating? How much water or fluids is this person taking? And are the food or the nourishment or the supplement the person is taking, is it the appropriate one? I'll address in diabetic patients, when they have a skin breakdown, I hear nurses go, oh, the glucose level is uncontrolled. Okay, so that by itself, if that sugar level of that patient is not well controlled, it's not going to help in the healing of that wound. But then again, if that individual, because of XY reason, the family member has completely taken food groups out of their diet, and lately I have been hearing that people are not eating as many fruits because they are higher in carbohydrates or they have the natural sugar. So, of course, in a diabetic patient, fruits is a way of giving extra vitamins and minerals. But if that individual is not getting that, how, and they're not supplementing them with a vitamin or with another nutrition supplement, how is the body going to be able to heal? Again, skin breakdown can be measured in different ways, not only on ulcers, but also, skin rash. You also can look at the person's face, if their lips are cracked, or they're, people say, oh, I'm getting a mouth sore, and necessarily it's not a mouth sore, it's actually a deficiency. And so, again, you need to inquire as the staff, if you're looking at things like that, when was the last person that person had a blood test that would measure the different lab values to address, okay, is that person having a vitamin C or mineral deficiency? In regards to irritability, when I was planning for this presentation, I know I'm not malnourished, but lately I have been kind of irritable. I go, okay, is it stress or is it actually, am I eating the right things? But I put the humor in my presentation because at times when you have homebound patients and you are the caregiver and you are around that person 24/7 and you think that the person's lack of humor, irritability, or just bout of anger, you might think, oh, it's because they're tired of being in bed or because of the diagnosis or whatever. But how often do we think is that change in mood associated with poor nutrition or with poor hydration? So if you're listening to me and you feel irritable, check when was the last time you ate. No, I'm kidding.
Judy, I know that my daughter, if she doesn't eat, she turns into like one of those gremlins. So, I mean, I guess just a drop in blood sugar. But it really is important. It's something that we don't first think of as irritability being a sign of an issue related to nutrition. But it is.
Correct. And then the other thing, when you think about irritability, it also at times, and here I'm going to play the devil's advocate, sometimes mood changes could be because of medications. Mm-hmm. And it could be because of medication interactions in different kinds of foods or the lack of food when you give the medication. Mm-hmm. But then again, the caregiver, or if you have a home health staff that is used to seeing the patient all the time when they're irritable, they're assuming that that patient is irritable by nature. And in reality, it could be a sign of high or low glucose. It could be a sign of starvation. It could be different things. So, when I hear comments about patients and their mood, I always inquire and say, well, have you checked on, how often have they eaten, how much have they drank, or what are the medications that you're giving close next to each other? I'll give you an example in regards to HIV patients, and I know that, some of them might be bedbound, but the types of medications that they take, some medications, if they take them too close to a high fatty meal, it can affect their mood disorder, and it can also, not disorder their mood, and it can also, in some cases, it can cause hallucinations. So there again, sometimes if you see behavior changes in patients that you deal with, the question is to ask, what's going on? Again, for concentration, you might ask a homebound patient, a home health patient, what day is it today? If the person doesn't have issues with dementia, if the person doesn't have issues with, trauma, brain trauma, head trauma, injury, and you ask a question and they can't answer, sometimes that is a sign that that individual is not eating appropriately, or when was the last time they ate. The other, as simple, and I know that home care staff does check on body, I hope they check on temperatures of the patient, but then again, how adequate is for that person, and I usually ask people when they complain in this building that they're too hot or too cold, I'm like, you have poor circulation, or are you sure you're eating properly? Because the issue of body temperature, can be a sign of not proper nutrition or proper hydration. And so again, and I'm looking at two friends in the audience, and I do ask them that if they have eaten properly or not. But the other thing is, and I take time to explain this, that we live in Alabama, and yes, we don't have bitter cold months or cold temperatures, but we also have very hot summers. And so if you are doing an assessment on an individual and you know that the air in the house is, normal temperature, and I'm not going to say normal because it's different upon the eye of the beholder, but if you touch a person and you see that they're either too cold or too hot, that's also that something is going on. And that it could be that you go, okay, this person doesn't have an infection. Is this person are they coming with a bug or a virus? But sometimes it's as simple as not keeping proper body temperature for the individual to show it's their body saying, I'm being depleted or malnourished in a way. Again, diarrhea. Diarrhea is, it's a symptom and a sign of so many things. But then again, if an individual is, for example, patients that have Crohn's disease, it would be hard to assess malnutrition just based on diarrhea, because that is that's their normalcy, is to have different bouts of diarrhea a day. But in an individual that does not have that diagnosis, when you see that they have persistent diarrhea, that you see that they are not on antibiotics, that you're not on medications, that the side effect is diarrhea, then what is going on? Are there issues with absorption? Are there issues with, their GI system? Are there issues with, the body? For example, a patient that has been on fluids and then all of a sudden they get a big meal, they're going to get an osmolality imbalance that is going to cause diarrhea. But how does a person that is taking care of that patient know that that's going on? Right? So that's another issue and I'll address it with treatment. And then, of course, depression. 9 out of 10 people deal with depression at one point in time, if not 10 out of 10. And then again, if you are having a blue day or you are having bouts of depression, your food intake, the way you eat, the kind of foods that you eat. Do you eat with people? And of course, we're addressing people in the home. Do they not want to be around other people? They are not interested in meals. They're not interested in eating. So again, if a person has gotten, and I say this to other people, if a person has gotten the diagnosis of depression, it is one of the issues that you have to be more in tune of when they eat, how much they drink, and are they around other people when they're eating? Because sometimes a very depressed person will not want to eat or be around others, and sometimes it could be as sneaky as to chunk the food and not eat it. But if you don't know that, how do you know that that individual is eating? So, if you're in a home setting and you know that there is, and I don't call it mental health, I call it brain disorder. If there is a brain disorder going on, it's a thing of checking, okay, what's happening. And I don't also think on the sense of depression, but I also think on the sense of anxiety. Some people tend to eat based on their emotions. And so at the beginning I said that malnutrition, it not only means being thin, but also it means a severely overweight person could be malnourished, the extra weight, the extreme. And so sometimes people that have issues with anxiety and anxiety attack, then they can have the issues how much food or not food they consume. So, what are some of the causes of malnutrition? And I hope that you are still interested in the topic and not falling asleep. But some of the causes of medical conditions can cause malnutrition. And again, you might not be wanting to have malnutrition, but it is what diagnosis do you have that it will affect your health in regards to the part of the body that will affect the ability for you to digest or absorb nutrients. And in here I'm going to use an individual that is going through chemotherapy. And it depends on the chemotherapy treatment. It depends what part of the body, first of all, they're attacking with the cancer. But again, that individual might be wanting to eat and might be eating the right kind of foods. But based on the treatment, based on the medication, it's nothing that they can do because it's affecting the absorption of or digestion of certain nutrients. And then again, if it's an individual that is on chemotherapy and they develop severe nausea and vomiting, sometimes even the medication they get for the nausea and the vomiting can affect the absorption of nutrients. So in regards to the condition, it's more intense for the dietitian, it's more intense for the healthcare provider. It can be very confusing for the nurse or the nurse aide in regards to, okay, this individual is eating, this individual is drinking, this individual is getting supposedly some nourishment, some supplements. But if we're not looking at the gut and how the gut is affected because of the chemotherapy or the radiation, how would you address that? In regards to, a condition that makes swallowing painful or difficult, again, if it's an individual that is dealing with, cancer of the throat or the esophagus, or it could be, we live in a state that is football fans, and I'm not going to go with Auburn or Alabama. I'm going to leave them out. But if you had trauma to the neck and it's causing swallowing problems, you might say, oh, I got hit, no problem, but it can prolong. Again, in patients that are stroke victims, and it depends on how quickly they got treatment. If swallowing is an issue or they have difficulty swallowing and they have almost choked, then you have to address the issue of fear of eating and swallowing. And sometimes you cannot address the issue of fear because they're not going to tell you, I'm afraid of swallowing or drinking. So again, what is the condition that is causing that? Again, conditions that cause lack of appetite. Some medications, and I tend to tell people, look at the signs and symptoms or side effects of medications. But then I also try not to read the signs and symptoms of or the symptoms or side effects of a medication, because a lot of the times a medication just by itself can cause lack or increase of appetite. But again, in regards to what are some of the causes of malnutrition, I already went into a little bit into cancer. If you have liver disease, if you have issues with malabsorption and you try to eat foods and, they have told you have to eat that are high in caloric value, and you're having liver conditions, then, of course, if it's a high fat, high protein food, and you're having problems with liver, then that's going to cause nausea or vomiting in the patient, and so therefore it will cause the issue of, no, I'm not going to eat that because it makes me feel bad. Individuals that have constant, persistent pain, that could be in itself a sign of, that can cause lack of appetite, because I don't know about you guys, but the times that I have taken medication for pain, it has literally knocked me out. So if you're asleep most of the time, how can you eat? Or if the pain is so bad, one of the first things that happens is it affects your wish and will to eat something. So again, where is the pain? How is it being treated? How is it being localized? How is it being addressed? And then, of course, persistent nausea. And again, a nausea could be a sign or a side effect of medications. It can be a sign or symptom of a condition, like there's patients that have anxiety attacks that have persistent nausea. It could be patients that are receiving different kind of treatments that can have persistent issues with nausea. I also tell we're addressing homebound patients and we're addressing medical conditions, but if you also have to deal with individuals that have alcoholism or alcohol problems, they can have persistent nausea from drinking too much all the time. Other things that can cause malnutrition is, what if your health condition is such that requires frequent hospital admissions? And when you get admitted to the hospital, the first thing depends how long it takes you to be admitted, and it's no attack or a hint for the hospitals, but just because of the process, people can go hours without drinking or eating anything. And especially if an individual is trying to figure out what's going on, the first thing they go is NPO, nothing by mouth. But then again, if it's a home health patient that gets constantly, and that's what we hope, that if you start looking for malnutrition, that their readmission decreases. Again, how often are they going to the hospital? How often do they're kept nothing by mouth, and then clear liquid, and then full liquid, and then finally as tolerated? But if you look at that period of time, and based on the health condition, it can deplete the person's nutritional values and if they're becoming malnourished or not. I have addressed already taking many different types of medications at the same time. Here I will address individuals that are HIV positive or have AIDS. They have to take a lot of medications, and so sometimes the medications they take, it can prevent absorption of certain nutrients. It can prevent absorption of protein. It can prevent absorption of calcium and vitamin C, and so different malabsorptions of some of the major nutrients can cause malnutrition in a patient. I have talked about mental health conditions. Again, here I will address a person that is dealing with schizophrenia or with severe mood disorders, where sometimes a person gets aversion to eating or drinking because they're afraid that the food is causing the symptoms. So, again, if you are dealing with individuals that have mental health conditions, what are they? Learn a little bit about the condition so that you know to address. If you're in doubt, questioning that person is having malnutrition issues, how can you address that with that patient? In regards to persistent diarrhea, I already touched that, but just diarrhea in itself is a sign of malnutrition. Is the person eating enough? Are they getting enough calories? Are they getting enough fiber? And then again, if it's a condition where you recommend, like if a person has diverticulitis or diverticulosis, do you recommend a high fiber diet? If the person has had, if they're dealing with colon cancer or have colon resection, what are some of the foods that they can eat? How much of the food they can eat at the same time? Because again, that can affect, the fluid and the movement of nutrients, and it can affect how the person is absorbing the nourishment. In regards to persistent vomiting, it's similar to the diarrhea. If it's the medication, if it's the condition, if it's a sign or symptom, if it's something that is because of nervousness, sometimes people have trauma to the throat, and just the fact that they touch or they put something in their mouth, it can cause the person to automatically vomit. And I know that my next topic, or my next cause of malnutrition, is eating disorder, and mainly it's higher in women than men. But in anorexia, or not necessarily anorexia, but in bulimic patients, where they can sometimes vomit up to 20 times a day, just the way they open their mouth can cause them to vomit. So again, if you're dealing with a home health patient that has as a diagnosis an eating disorder, it would be good to kind of know the history and the symptoms or how that individual has been in the past, because very unlikely that an anorexic and a person with anorexia nervosa by choice, not because of a symptom or a side effect of a condition, they just flat out don't want to eat. They're not going to admit it. So again, how do you know what kind of questions to ask and how to address that? And also going back to the people that have bulimia. Sometimes you can have a combination of bulimia and anorexia, and it is that they will eat, and then they induce themselves into vomiting, and so they vomit so much. Do you think that individual will have much absorption? No, because they're, yes, they eat, but then they make themselves vomit their, everything they have eaten. So, looking at causes of malnutrition, we talked about medical factors. Now I'm going to address physical factors. And some of the physical factors, for example, poor oral health. Another, something as simple for the home health person to ask, when was the last time that you saw a dentist? If you're homebound, the fact that you're going to remember, if your other issues is my heart is beating, I have issues with my lungs, I have issues with major arthritis, your teeth, your oral health is one of the last things to remember. But then again, poor oral health can affect, if you have issues with your gums, if you have issues with an uneven bite, if you have issues that you don't have teeth because they have been extracted, how can that person chew or eat properly? Although sometimes when people have dentures and people have poor feeding dentures, then food gets under their dentures, and so there's infection, and so they go, I don't want to eat much because I don't want to have problems with my mouth. But then again, something, you don't have to have a dietitian, you don't have to have a dentist to, just ask, are you having any problems chewing and swallowing? And if they say, yes, I'm having problems chewing, can you describe what are some of the symptoms? Is it painful? Is it that you cannot bite? Is it that it hurts you? Sometimes we tend to forget about our tongue, and yet some side effects of some medications or some diagnosis and even actual signs of malnutrition is mouth sores. But if you don't address them or you don't treat them, that can affect, your salivary secretion. It can affect how much you want to eat. It can affect the foods you choose to eat, because if you have an open sore, that can be for a lot of reasons. You would not want to eat something that is acid, that is going to burn. You wouldn't want to eat something that is high salty because it's going to burn. So again, we need to keep focus about our oral health. Then, the loss of appetite as a result of losing sense of smell and taste. Again, depends on the treatments. It depends on the individual. If we're dealing with people that have had major brain trauma, or they have had a stroke, or they are going through cancer treatment, the first thing that affects is the sense of smell and taste. In some individuals, the sense of smell could be much more than just the smell of food. It's like, I don't want to eat, just let me be. In the sense of taste, if you had trauma to the tongue, it depends on where the trauma of your tongue, it can affect just physically. It can affect what taste you can tolerate and which taste you can't. And so the physical disability or impairment that affects you to cook or shop for food. I know that if you live alone and you cannot drive, or you live alone and you don't have transportation, or you don't have to live in a remote area, you can live in a city and not have access to food, it can affect how, your access to any kind of food. So, some of the other causes besides medical and physical is social factors. And, we tend to think, every individual is unique. But then again, there's some people that were used to eating with a lot of people, and now they're homebound and they don't have anybody to eat. That affects how much they eat. If it was an individual that depended on a partner for them to cook for them or to go buy food, and that individual is gone. We tend to take it for granted, our mobility and our function. And as a matter of fact, today when I was driving to work, there was somebody that had dealt with stage 4 cancer twice, and one of the things he said that he was so lucky to have survived the second bout was how he took it for granted just to move from his bed to the dining room, or from his bed to the chair, without having tubes coming out of their side. So again, we tend to take it for granted, our mobility, just from one place to the other. In regards to dealing with alcohol or drug dependency, if they're addicted, that they're drinking, and they forget to eat, and just the fact of high consumption of alcohol, it causes malabsorption of nutrients. And so, or if you're so dependent to some drugs that affect your thought process, then how do you know what you're eating and when you're eating? And then, of course, income. Do you have enough money? And so I know we have Renee Carpenter in the audience. And so I just wanted to ask you, Renee, if you were dealing with homebound patients and they were telling, the staff that, that their fixed income is being used for medications, or that, the neighbor that used to bring food for them passed away, or for whatever reason, the resources for them to have some kind of a healthy meal happens, what are some of the resources that are there for an individual to link into or for the home health staff to assist?
Well, most every community has a food bank or a church that offers a food bank. There's also food stamps, or what's called SNAP now. And a lot of people don't realize that nutrition supplements like Ensure and Boost can be purchased with food stamps.
Okay.
So that's a possibility also. One thing that you mentioned that I wanted to elaborate on a little bit is people who tend to depend on others to assist them as far as mobility is concerned. We've seen a lot of times, especially as the caregiver either gets older or if it's a younger person who's the patient, as they get older, they will reduce their food intake because they don't want to gain weight. And that's because they don't want to become a burden on the caregiver, or they don't want to cause an injury to the caregiver. So that's something else to look at. Also, utilities. Just because a person has electricity doesn't mean they have the ability to cook. They may have a gas stove, and unless you ask that question, you don't know. So if they can't afford the gas, then they may be cooking simply with a microwave or a hot plate, even though they have electricity.
Correct.
As far as other resources, the Department of Senior Services has quite a bit of resources for nutrition. There's Meals on Wheels in some places. So I would recommend contacting the local social worker in that health department.
In regards to the Meals on Wheels, does the referral have to come from a case manager, or can a family member contact? Do you know about meals? I haven't.
Usually a family member.
Okay.
They'll take a referral from anybody.
Okay. And the question I had for you in regards to the food bank, if an individual, can somebody in representation of that individual go get food from the food bank, or does that individual has to go themselves?
It's probably going to vary from place to place, but anyone who's homebound, that should not be a deterrent.
Okay. Also, churches in some areas will provide food for people that are homebound, correct?
Right, that's
Okay.
right.
So, in regards to SNAP, and here I'm playing the devil's advocate, and I'm not putting you on the spot. But SNAP now, you have that EBT card, right?
Right.
And I guess if that individual that goes and purchase food for that homebound person, they would have the PIN, they could purchase food, and they don't ask for an ID or whatever, so that shouldn't be a barrier, correct?
Right, that's correct.
Okay. All right, well, thank you. In regards to moving along, I do want to commend the Academy for Nutrition and Dietetics, and I didn't include it in your handouts because they did have a copyright, but I do challenge you or encourage you to Google the recommendations for malnutrition that the Academy brought up on the screen. You will see the chart, and I'm going to talk a little bit about that. But it's very concise, and it's a document that you could read yourself, or you can copy or download, but I know that I couldn't put it for all because it had a copyright. But it's really good if you are having to address from a nurse perspective, aide perspective, or any kind of dietitian perspective in regards to, what are some of the, where would you go in regards if an individual was dealing with malnutrition. And so if you look at this chart, I know that it's kind of busy, but at the top it's if an individual has compromised intake or loss of body mass, then you look, does that individual has inflammation present? If that individual has inflammation present, then how much is the inflammation? How much is the swelling? And so then if the individual has swelling, then you look at what is the chronic condition, the chronic disease that individual is dealing with. Is it an organ failure? Is it the pancreas? Is it an immunocompromised condition like rheumatoid arthritis or fibromyalgia? Or in some scenarios, it could be just plain obesity. Is that the inflammation caused because of the weight that is putting on the patient? So then if you go to the right the left of the chart, and you look at is inflammation present or not. And if it's no, then is it actual the weight loss, the malnutrition? Is it because the person is starving? Is the person not getting enough nourishment that's causing the malnutrition? And previously we talked about anorexia and anorexia nervosa or bulimia, that are some of the causes that will cause somebody to not eat at all, but it's self-induced, not because of medication or a side effect. So then if you look at the right of the chart, it says if there is inflammation, is it because of an inflammatory response? Is it because of an acute or injury-related malnutrition, i.e. people that have been dealing with major infections with MRSA, people that are dealing with major trauma, people that deal with burns, or, I see a lot closed head injury. We take it for granted. And of course, if it's a homebound patient that has had, like in a vehicular accident, and they had trauma injury, and sometimes it's not diagnosed, but sometimes there is injury that affects the motor skills, that affects the memory of the person, have they eaten or not? Does it affect the amount of food? Does it affect the kind of food that they eat? So one of the, and I'm going to move forward. This chart is, again, in this article that the Academy for Nutrition and Dietetics, and it explains in detail, what to do. So I highly encourage for you guys that are interested to read about it. And so what should you do? Okay, now you question, you sort of have kind of diagnosed, you kind of know the reason why that person is malnourished. So what next? Again, if you have a dietitian in the world and in your team, it would be awesome for them to help you diagnose. But if not, as the primary provider, what are you doing in addressing nutrition for the patient? Sometimes some of the doctors go, where are you coming from with that? But I think that, again, the treatment will vary based on, how severely that patient is malnourished. Will you have to make diet changes? If it's an individual, and I'll use the example of an eating disorder patient, if that person has not eaten for a long period of time, you're not going to expect for them to eat all of a sudden 3 meals a day when they have starved themselves for days. So you would do a gradual increase of calories. You would look based on their BMI, their body mass index, based on their activity, based on their age. You would calculate how many calories they need, again, how many carbohydrates, minerals, but then that would, I know that some people do not have the knowledge or not feel comfortable, so it would be good to get a dietary consult in the sense so that they can calculate that, or if the doctor calculates that. But I usually use as a baseline, if you're thinking just on top of your head, depends on the condition of the individual. If they're going through a lot of stress, on just an overall, is 25 to 30 calories per kilogram. Protein, again, it depends on the age of the individual and the diagnosis. It can be anywhere from 0.8 to 1 gram, or it can be 1 to 1.2 grams of protein per kilogram. And then again, the fluids, usually you calculate, if it's not somebody that is on fluid restriction, you kind of base it on 25 to 30 cc's of fluids per kilogram. I know nurses get involved in doing that because if it's somebody on fluid restriction, then they have to look at that. And so based on the recommendation, and sometimes you will get patients that already are on a nutrition supplement. Is that nutrition supplement the most appropriate for that patient? Sometimes because of quickness, or because it's asked at the last moment, they will prescribe just your typical nutrition supplement. And because I don't want to go with Ross versus Mead Johnson or Nestle or the different companies, I'm going to speak in general. But sometimes there are more specialized supplements that individual can have that could be prescribed, but then it's the issue in the public health will come out in me. Does that individual have the resources? Do they have the insurance to cover? And sometimes insurance will not cover for a nutrition supplement if it's not given via tube. So again, whatever supplement you recommend will have to be based on, the coverage, the insurance, the diagnosis. But most of the time, if you're questioning malnutrition, it would be a good way to help increase caloric intake and nutritional intake. So again, we assuming that the individual doesn't have any issues with swallowing or chewing or even the issue of sitting and not having issues with aspiration. Because again, if you have individuals that have recurrent pneumonia, is the pneumonia caused because of aspiration? Is the aspiration caused because of malnutrition? So it's kind of like a chain that you question, okay, what is the culprit of the problem of that patient? But if you as the nurse, the aide, the home health, who else goes to see him, the case manager, in some areas there might be a dietitian if they're working with public health, then what is causing the lack of swallowing, the lack of eating? Of course, dysphagia. And then again, do you have the nerve to say, okay, I would like this patient to be seen by a speech therapist, by a language therapist, an occupational therapist? And it takes an individual with that training to be able to look at a patient without having to do a swallow varium where you have to take the person into an x-ray, into a radiology clinic. A speech therapist can do the analysis just based on how long the person keeps the food in their mouth, the liquid in their mouth. Do they gag? Do they cough? Do they choke as they're talking? So some of those things would be a good way if you question that that the person is having problems swallowing food. Now I have a question for you, Jackie. Does public health, home health, do you have access to speech therapists?
In some areas. It's not widely available, but yes.
Okay. So if in an area there's not one that could come to the house, then would the procedure be that you would ask their primary provider and then they would make the referral? Okay. All right. So moving along. Again, if after you have done the assessment, you have looked at the cause of malnutrition, you have looked at what are some of the issues, sometimes the gut is not working, i.e. the mouth, the swallowing piece, so you have to go into artificial methods of feeding. I know that there are several patients that have been stroke patients that get discharged to the house that are probably on a PEG feeding, which is a percutaneous endoscopy, gastrostomy, and all that blur to just tell you that it's a tube that is directly into your stomach. Some patients, if they think it's going to be a short term, they will use a nasogastric tube, an NG tube. I personally don't care for those as a dietitian because they're so uncomfortable. The patient tries to fight, trying to get it out. Can you imagine having a tube down your throat, your nose, into your throat, and that you see that food is going in there? And if you already have issues of fear, you have issues of nausea, you have issues of vomiting, just having that tube in your throat, I want to think about it. But some patients, some providers, some family members, when they hear being fed through alternative methods, it's go, oh, let's try with the NG tube, which sometimes that can deter the patient from accepting having that done. So, I usually, and I do push for PEGs in the sense if I know that it's going to be a prolonged time, if I know that that patient has had, a major stroke, that even through therapy that individual won't be able to swallow properly. And if I see that a person has had several bouts of pneumonia, and if I see that that person has had some swelling around the lungs, I go, it would be better to feed. And if that person has a skin breakdown, which you would think that it would need extra caloric, protein, nutritional intake to promote wound healing, it would be simpler to feed through a PEG. Then, of course, there are some cases where patients, if they have had major trauma to the stomach, to the liver, to the pancreas, either through accident or cancer or whatever it might be, that are fed at home through parental nutrition. I know that's more the exception than the rule, but then that's a way of refeeding an individual, but it's more complex. You have to be extra cautious with the infection site because it's going straight to the central line. It's pre-digested supplement. So, these are some ways that could assist in feeding the patient. I said that I wasn't going to go there, but I am going to go there in the importance, and I know that we have 2 case managers in the room, of the importance of having a living will. Because if you're in a situation or you're a homebound patient that declining has been seen, lab tests show that that individual has some malnutrition and they have to be fed, the question is, what if that person loses their ability to make decisions? What if the families have difference of opinion in regards to prolonging the life of an individual through a tube? So that is also important, and I don't know, I'm here going out in the scenario of homebound patients. Who checks that an individual has a living will? Do you know?
That is a standard question, regardless of what setting you're in. I work in acute care some, and then our home care as well. That's part of the assessment, is to ask, do you have a living will? And if you don't, in most settings, I know with the settings I'm working in, that if they don't have one, then we ask if they would like information. And most of the institutions or agencies that you would be working in would have a protocol for that, so that they could be provided that information. We don't do it for them. We don't provide them the forms, but we could provide them information on how they could pursue that if they wanted to.
And the reason why I brought that up is because from the standpoint of a dietitian, that would be something that
Yes,
you want to have
absolutely.
to clear, because I don't know where the legality is now, but you wouldn't want to promote something and then it would be an issue of
Absolutely.
quarrel among family
Absolutely.
members. Thank you. In regards to who is at risk of malnutrition, is individuals, again, we have been talking about that, individuals that have an acute or chronic condition. Unfortunately, the elderly, and not because, Renee addressed this, and thank you for addressing that, the issue of, okay, I'm going to have somebody help me get up, somebody change my clothes, somebody bathe me, I don't want to gain weight. The fact that they feel isolated, I know young people that live alone that at times they don't feel like eating because they're eating by themselves. Again, individuals that have a mental health condition. I know we have addressed depression, but I want to include all the different brain disorders can affect, wanningly or not, the way that you eat, the things that you eat, because sometimes the medication is the one that causes the side
Medication,
effect.
and particularly like you mentioned, schizophrenia, because they may have some paranoia
Right.
thoughts and just know that the food is poison, or,
Correct. And so, again, we tend to deal with individuals, and some people might tend to stay away from the mental diagnosis, but sometimes that is the cause of a lot of the symptoms, the behaviors, the side effects. And then, again, is individuals who have difficulty swallowing. And we already discussed the issue of utilizing or a referral to a speech therapist, occupational therapist. And then, at times it could be the swallowing. And when I mention oral health, I failed to say that sometimes poor dentures can cause, the issue of swallowing and the fear of the individual in what they eat and how much they eat. So when you think also people that, and I am not trying to say that living in an assisted living facility will cause you malnutrition, no, but the fact that you live and if you live in an assisted living, you still have some dependency, some independency, and so we tend to think, that individual is getting food, that individual is eating, that individual is, around people that will increase their spirits to eat, but not.
That's a good point. They may have a facility, I'm familiar with some, and they provide meals, but they may not be checking, they may not know if they came down for the meal or not. So That's a real good point.
And then the other thing, even though we address home delivered meals, and I know that they leave, the meal is enough, most of the time it will feed for 2 meals. But if you address, and I know that, because of time, and if we have time, we can address it later. But the issue that they have, I remember when I used to work in WIC, and I know we're talking about homebound patients, but people would get insulted when we would ask, do you have a working refrigerator, a working stove? And they go, what? But when you're dealing with homebound patients, if you're on a fixed income and it comes to medication or paying your gas, and like you said, if it's a gas stove, so what if they don't have the resources? But mainly, what if they don't have the stamina or the ability to ask for help and say, I don't have money and I need help for gas because my stove doesn't work. I know and I hope that the home health care staff, whichever your discipline is, that they're in tune, to check, does their microwave work, or does their stove work, their refrigerator. And, we tend to make the assumption that everybody has a microwave, but older people don't believe in putting stuff in there and within minutes to cook, even if they have it, because it's part of their culture, it's part of their belief. Again, who else is at risk of malnutrition is, we already talked the homebound patient, those individuals that have problems buying groceries, and yet, I haven't addressed, but, if you're homeless, and even though you're not homebound, if you're homeless and you haven't had a meal or you haven't had enough, and I know that after the break we're going to talk about hydration, how do you know if you have encountered or the home health staff is now dealing with somebody that is homeless? How do you know to address that? So I think one thing that I failed to mention when I was addressing with weight loss is that in regards to malnutrition, you can look at the BMI, although I don't care much about the BMI because it only looks at weight for height. It doesn't look at the individual. It doesn't look at the sickness. But the BMI is a quick parameter for you to look at where that person is in regards to malnutrition. And preparing for this talk, and also I always kind of read, if your BMI is less than 18.5, you automatically are diagnosed with malnutrition. Mm-hmm. However, I caution the staff, because you might have individuals that healthy, normal, no matter what, their metabolic rate is so high, they'll never be higher than 18.5. So again, if their BMI is 18.5 or less, and there's a diagnosis with it, yes, you can inquire about malnutrition. Some physicians, some healthcare providers will diagnose with protein calorie malnutrition if the BMI is less than 20. And yet, 20 is a normal weight. And because there are all kinds of things, diagnostic codes that can address malnutrition, what kind of malnutrition. However, in some states, they have become fearful of using those diagnoses because there's different parameters that you have to look at. And if, as they were doing audits, especially with Medicare reimbursement, some hospitals had to pay money back because the physician or the staff have used the code of protein calorie malnutrition, and one of the many parameters was not checked, so the money was taken back. So you're seeing when you diagnose and the patient gets discharged home, it will be really good to look at all the different things that would help in diagnosing somebody with malnutrition. So I think, Jackie, we're at a point that we could take a break. Okay. So we come back, at?
15 minutes.
In 15 minutes, so that would be 3:25.
Mm-hmm. Yes.
All right.
We'll return in about 15 minutes.
Welcome back. To my left, I have a treat for you guys. It's Sarah Foster. She is a dietetic intern working with the division, Nutrition and Physical Division within Public Health. And what I wanted to do was not only show you guys, but kind of model how a dietitian would do an assessment to look if a patient is malnourished or dehydrated, and she has the treat because she's the dietitian, and I'm going to play the patient, so hang in there with us, and just so that you know what it entails to do a proper assessment when you're dealing with malnutrition and dehydration. So welcome, Sarah.
Thank you. Okay, good afternoon, Miss Julia. How are you doing today?
Well, I'm sort of all right.
All right? Mm-hmm. What's going on?
Oh, I can barely lift my hand. I'm tired. I'm grouchy. Not feeling very good.
Okay, well, I just want to ask you a few questions. So in the past 2 weeks, how has your appetite been?
Well, some days I have eaten like a horse, and some days I can barely drink a glass of water.
Okay, so it's varied quite a bit.
Yes.
In the past several days, would you rate your appetite as good, fair, or poor?
Can it be between poor and fair?
It can.
All right.
Well, tell me what you had to eat yesterday.
You're asking me, do you remember what you ate yesterday?
Some of it.
Okay.
Just try to think.
All right, let me think.
Starting with breakfast. Did you eat breakfast?
Well, I had to go to the doctor.
Okay.
And you know how long it takes to go to the doctor. And they had told me not to eat anything because I was going to have labs done.
Okay.
So I did drink coffee, but I don't put anything in my coffee.
Okay.
And so then I didn't eat anything. And then from my labs, because my blood pressure and because my body temperature was kind of crazy, they sent me to see another specialist. No time to eat. So I didn't eat until about 3.
Okay.
And then I was so hungry that I just vacuumed. Can't remember. I had leftovers. I had rice and I had chicken, and then I ate a whole donut, and then I had a whole can of Coke, and then I ate something else. But then, you know what? I ended up having diarrhea.
Okay, you did?
So then my stomach was hurting, and then I didn't want any more leftovers, so I just ate frozen pizza for dinner.
Okay. Well, yesterday doesn't sound like it's a typical day for you. So in a typical day, do you usually have breakfast, lunch, and dinner, or do you typically skip breakfast or skip lunch?
Well, if I have friends to come over, I do have lunch and dinner. And it all depends. If I have slept well the night before, I might have breakfast. But if not, I only drink coffee.
Okay.
Don't tell me I can't drink coffee, because then I won't like you anymore.
You can keep drinking your coffee.
Thank you.
Well, to your knowledge, have you had any weight loss in the past 6 months?
I think I've lost like 10 pounds.
Maybe 10 pounds?
Mm-hmm.
So have you noticed that your clothes are fitting a little looser, or do you weigh yourself?
Well, I have a scale because I have been going through chemotherapy and radiation, and they kind of told me about swelling. And so I kind of weigh myself, but I don't know if my scale works. But I have noticed that the weight has shown on my scale.
Okay.
But I don't try to tell people that because I don't want them to feed me through a tube and that kind of stuff.
Okay. Well, thank you for voicing your concern about that.
Thank you.
So your weight loss wasn't intentional. You weren't trying to lose weight.
No. Because they tell me that I have to eat in order to keep having my treatments. You're not going to ask them to feed me through a tube, are you?
Not at this time, no.
All right.
Okay. And do you know what your usual body weight is?
Do we have to talk about that? It's been around 150.
Okay.
But my license is 120.
Well, in the past few weeks, I know you said that you've had diarrhea after that meal, but normally have you been experiencing nausea or vomiting or more diarrhea?
Well, usually the day after my chemo treatment, I do have a lot of vomiting. It's beyond nausea. And they give me this pill that makes me sleep forever. So when do I eat?
So you aren't eating the day after chemo?
Mm-mm.
Okay. Do you have any problems with chewing?
No. I've noticed that after my chemo treatment, sometimes I might have, it feels like a beginning of a blister.
Okay.
And so it's kind of bothersome, but, you know, they tell me to rinse my mouth with salty water, and anyway, I'm glad to be alive.
Yes, ma'am. And does that help when you rinse with the salt water? Does that alleviate some of the pain?
Some. But, you know, I kind of ignore it.
Well, we'll talk about some things that you can do later to
Just
help
don't
with
feed
the
me
pain.
through a tube.
Okay. And what about swallowing problems? Do you ever feel like you get choked up after eating or drinking certain types of liquids?
Mm-mm.
No? Okay.
Is that a side effect of chemotherapy, you think?
Not the swallowing. The problems chewing could,
Oh.
or the blisters could be from your chemo. You shouldn't have any swallowing problems.
All right. Good.
And do you have any difficulty buying groceries or preparing meals at home?
Now, you know what? I have issues. People bring, they're kind, and I'm thankful. I don't want to sound like I'm griping, but after each treatment, they bring me so much food that sometimes seeing so much food, I don't feel like eating. But no, I'm lucky in that sense that I have good support.
Okay. Okay, and in a typical day, how many glasses of water or fluids do you drink?
Can I count my coffee?
Yes.
All
you
right.
can
Well,
count
I
your coffee.
drink like 6 cups of coffee. Although I tell my doctor I drink 2 only. And, you know, you have to tell them what they want to hear, not what really happens. And then I drink some water and a little bit of juice.
Okay. Well, your doctor might be on the right track. You might not want to drink as much coffee. We can count that as fluids, and I'm glad you're getting the fluids, but maybe you could substitute one of those cups of coffee for milk or water.
I don't care for milk. Can I drink soda?
What kind of soda?
The real
The
thing.
real thing?
Mm-hmm.
I would rather you not. I'd rather it be water, but you could do a diet soda.
I'll try water.
Okay.
I'll try.
You could even flavor it with some, Flavor Aid or something.
Can I flavor it with alcohol?
Better not.
Mm.
And how about, do you ever feel thirsty or have a dry mouth? Or how about your skin? Is it ever dry?
No. Mind you, after I go through radiation, it's kind of dry, but only in the area where it's being radiated. But the rest, no. And I put lotion every day.
Okay, good. Do you feel thirsty throughout the day, like normal before you started your chemo?
No. I usually have something to drink because when I feel kind of weak and fatigued, I just have it there. But there's times where I don't even feel like drinking that.
Okay.
Is it looking like I'm going to be fed through a tube?
No, ma'am, not right now.
Phew. Good. I guess I'm telling you what you want to hear.
Well, I want you to be honest with me.
I am being honest.
Okay. Do you ever experience cramping, headaches, dizziness, or lightheadedness?
Lightheadedness.
Lightheadedness.
Mm-hmm.
And is that after, being up and walking, moving around, or is that just when you're resting?
Sometimes it's when I'm sitting and then I get up.
Okay.
And but I don't know if that's a side effect of everything that is going on, or does that mean I'm not getting enough water?
It could potentially mean that you're a little dehydrated. Your coffee, all that caffeine, it can cause you to be more dehydrated. It has a diuretic effect. That's what we're kind of looking at to try to determine if you are dehydrated or not.
All right.
What about your urine output? Has it changed? Have you noticed a decrease, or is it about the same as it normally is?
No, it's normal. And one time I was told that I could tell how much I was drinking if I looked at the color of my urine, but I don't like to see my stuff, but I do check from time to time.
Well, that has some truth to it. So is your urine normally a pale yellow color, or is it normally darker?
No, pale.
Pale.
Mhm.
Okay.
Although sometimes the medication makes it smell different, so I wonder if I'm drinking enough water or not, or if it's just, sometimes when you drink vitamins, your urine smells like it.
Yeah, it could be the medications, or it could be that maybe you do need a little extra fluid that day.
All right.
Okay. Well, those are all the questions that I have for you. Do you have some questions for me?
Well, I want to know what do I need to do on the days that I just don't feel like eating
You don't
much?
feel well. Well, right now you're not taking any supplements, right? Like Ensure, Boost, or anything like that?
No, because I don't want to be fed through a tube, I told you.
Well, some supplements you can drink orally, just drink it like a normal beverage. So we can talk about some choices that you might want to try for those. Some other things that you can do with like your mouth sores is sucking on cold, like ice cubes or popsicles, that kind of thing. That could be something that maybe would be better tolerated. You could keep down easier. With the diarrhea, it looked like you were having a lot of high-fat foods. You could try eating more fruits and vegetables. That might help.
But where's the
that?
reasoning? Because of being on chemo, they tell me I have to be extra careful and that I have to soak them in water and wash them with soap. That's too much effort.
That's too much effort.
Well, the canned fruits or frozen do the
You could do
thing?
the canned or frozen,
Okay.
right? They're wanting you to make sure that those fruits and vegetables are clean,
Okay.
since you have a weakened immune system, but you definitely can do fresh or frozen fruits and vegetables, and that would be a great choice.
All right. Does the supplement, do they taste like milk?
They don't. They do not contain milk, so you should tolerate them. And they do, have a milky texture, but they're flavored chocolate, vanilla, strawberry, so hopefully we could find something that you would like.
Does the insurance pay for that?
Sometimes. Or at least they can help or give you a coupon, or we can talk about those things also.
All right.
Does that sound good?
Yes, ma'am.
Okay.
Thank you. Thank you for
welcome.
coming to see me. So, I hope that you enjoyed that interaction, so that if you heard the questions that Sarah asked me, there are some questions that you can ask your patients. You don't have to be a dietitian to ask those questions, but when you put all the information together, it would help to run it by somebody that has training in dealing with, with proper nutrition. So, Sarah, thank you for that. You did an excellent job, by the way, and I was trying to be mischievous, but you picked up on that, so good. But as we were doing our interaction, I don't know if you noticed that I said, well, I say this to my doctor, or I say this to my provider. Sometimes when we're fearful, and of course the patient, myself, was fearful of being fed through a tube, we tend to answer how our provider wants to answer. And so I just caution you on that. And I know that you have gotten the training on how to ask a question in different ways to try to think or get the answer that you want. So moving along, we're going to talk about hydration now, which is the latter part of our program, and it's one of the most important things. And I know that Sarah did ask several questions on how much I was drinking, what I was drinking, and how are ways that you can tell if that person is hydrated appropriately. And so again, you can have the best provider, you can have the best medication, you can have the best foods, but if you're not hydrated enough, you need fluids to stay alive. So how do you know how much do you really need? What do you need to count in the quest to stay hydrated? Again, if we're dealing with issues of patients that are homebound or individuals that have extra need for hydration, I know during our role play, she asked me about different fluids and different things, and those are the questions that you need to ask to ensure that the individual is drinking appropriately. Ideally, we would want for people to drink water, and Again, a lot of people, when you ask the question, how much fluid are you drinking, they don't tend to think about water. They tend to think about the tea, the coffee, the Kool-Aid, the punch, the alcohol, but never water. However, especially when you're dealing with people that might be suffering of malnutrition or dehydration, water is one of the best, actually is the best source to hydrate your body. And again, I want you to know that 65%, if not 70% of your body is fluid. So therefore, you need that much fluid just to keep your normal body functions going. If an individual is going through stress, if an individual is going through treatments, or if an individual has had or is having trauma, there is more need for hydration. Not only just to stay alive, but for wound healing, for cell regeneration, for tissue generation, and just for body functions, organ functions. So it's really important to ask the person or yourself, how much water does that individual have to have every day to keep a normal? And then again, how do you define normal? Is that person's normalcy totally different than yours? Are your water needs, your hydration needs different? And the factors that you have to think about, not only the diagnosis, the sex of the person, the height, the weight, the body functions. Again, if you're dealing with people that have issues with their kidneys or issues with their bladder, sometimes you have to kind of restrict. If people are having emphysema, if people have a COPD, pulmonary disease, you have to watch the amount of fluid that individual is taking. You cannot just go, like I was telling you previously, that is about 30 cc's, 30 mLs per kilogram. That is kind of like the standard, but you also have to look at the needs of the individual. So, again, if a person is not eating well, you can encourage them to drink liquids. I know that you heard through our role play, she was asking, well, what kind of liquids are you taking? You might suggest a nutrition supplement. Again, be cautious if you know that the individual or somebody in the family has issues with alcohol intake. When you're addressing fluid or hydration, it doesn't mean alcohol. You saw when Sarah was telling me that I could add flavor to my water, I asked the question, can I add alcohol? Because some people think, and some people, unfortunately, that's the only way that they might drink water. And so, again, we address the issue of caffeine. Caffeine could be not only a diuretic, but also a laxative. Mind you, that's my only addiction. So when I hear caffeine, I'm like, oh, don't tell me I cannot drink coffee, because I will challenge people there. However, though, in individuals that are having issues drinking water, or they're having issues with skin breakdown, again, the sources of their fluid is really important. I love the way how Sarah said you might drink juice or you might drink milk, and I know that I frown because I don't care for milk, but there's other ways that we could incorporate the milk in the daily intake. Again, issues, it depends on the diagnosis, it depends on your condition, always, and I'm not saying that the dietitian is the person only that knows, but always check with your healthcare provider, i.e. your physician, because they're the ones that are monitoring, how much of fluid, if you're on a restriction, how much fluid you need, how much fluid extra you need to have. And again, people tend to ask me, well, Julia, what's the normal amount of water that I should drink a day? I tend not to say out of the open because it's individualized. Yes, we tend to say 8 glasses of water a day, but for some people that are having issues, and you mentioned dry skin, some people that are going through radiation treatment. I remember when I was going through radiation, I was asked, how much water are you drinking? And I made a point of drinking extra water because it helps in wound healing and, for skin regeneration. So, how our tips to prevent dehydration, or what are some things that you can do if you're questioning that the person is drinking enough fluids. Again, offer clear fluids if there's issues with nausea and vomiting and diarrhea. Offer clear fluids such as water, broth. I wrote here sports drinks, but I will caution you in regards to what sports drinks you suggest, because in some, the sodium and the potassium might be a little bit high. And if it's an individual that is having hard cardiovascular issues, heart arrhythmia, you want to kind of keep a watch on the electrolytes, because they might be taking the medication like instructed, they might be eating appropriately, but if they're having too much sodium or too much potassium, that might cause, an effect on their heart rhythm and stuff. Again, if it's somebody that is bedbound or chair-bound, and, we address things that we take for granted in mobility, but if it's somebody that has to be bedbound, there's different gadgets that you can use to assist a person in drinking. There's squeeze bottles, there's different kinds of straws. If it's a person that has Alzheimer's, but Parkinson and shaking is the issue, I caution you about giving them sippy cups, because sometimes they feel insulted because they think I'm regressing to my childhood years. But there's different cups now that you can give them that have a lid that can facilitate the person in drinking fluids. Another way, when I do counseling or I'm doing an assessment and they say, oh, I flat out hate water, the city water tastes awful, my well water, I was told that I could not drink it because the water is contaminated, I don't have money to buy water bottles. Then I say, well, you can boil water and you can make ice. And ice is another way to increase fluid intake, and regardless of what, not in alcoholic beverages, but if they put it in juice and stuff, it's a way of them, ice. Or if they're having issue with nausea and vomiting and they say to chew on ice, that's another way to increase fluid intake in an individual. I told you that I was mainly going to be addressing adults, but if you're dealing with pediatric or children, and there's an issue of dehydration, either because of a condition or because of a virus or because for whatever reason that child has had, I remember the days of rotavirus. Again, it's important to continue to, if it's an infant, to continue to nurse as often as you have nursed, and to make sure that if it's a bottle-fed baby, that baby is getting enough fluids. How do you know if in an infant, and I'm not going to go too much in detail on that, but if an infant, how do you know on an infant, a toddler, if they're hydrated enough? You look at the number of diapers, wet diapers that they have. Ideally, you would want a bowel movement, but if that baby has been dehydrated and vomiting, as long as you know that they have from 5 to 7 wet diapers, that's another way of knowing that that infant is getting enough fluids. Also, you look at how wet their mouth is, their eyes. You look at their cheeks, if they're sunken or not. And those are ways that the nurses probably can teach me more on infants, but that's from the dietitian standpoint of you, how you can keep hydration in children. If it's a toddler or an older child, you would see how many, you would count how many times they have gone to the bathroom. You would keep a record of how many cups or fluid ounces they have taken. And again, even if it's an adult and you're trying to rehydrate, there's all kinds of theories. But the theory that I always practice and I always say is to rehydrate with small amounts at a frequent time, not continuously, but, let the gut rest. I know a lot of people don't want to go NPO, nothing by mouth, but if a person has been vomiting for a longer period of time, it's good to keep them, nothing by mouth for several hours to give the gut time to rest, and then you can hydrate with half an ounce to an ounce every 20 minutes. That's how I have done it. It has worked with some of my patients, and with some, of course, it depends how much the issues they're going through. But again, so why are we so into the importance of water in the human body? Again, I told you that about 65% of your body is made out of fluid. It helps water or fluids help keep our temperature within a normal range. Especially if you're dealing with patients with joint pain or arthritis, it helps lubricate and cushion the joints. Also, it helps the spine, protect the spinal cord and sensitive issues, the different organs in your body. It also helps to get rid of waste. And again, you know, when you go to the bathroom, either you urinate or you have a bowel movement, that's a way of you getting rid of waste in your body. I tend to tell patients or people that do not have a kidney failure or chronic kidney disease that they're dealing with some swelling. The more fluid, the more hydration you have, the more you're going to go to the bathroom, the more you're going to excrete waste. And so again, that helps with getting rid of toxicity in your body. Some patients, again, I have seen this in HIV/AIDS patients, that they get rid of waste, you know, through perspiration, but again, they have to replenish, you know, their fluid balance. And again, you know, if you're dealing with individuals like people with Crohn's disease or people that have, you know, the latest is people that have gluten sensitivity and they have celiac disease, and the issue how many times they go to the bathroom, it's really important for those patients to know how much water they're taking. Again, water is necessary to replace normal urine and insensible fluid loss, regardless of what causes the fluid loss. You know, to replace, sometimes patients will have fluid loss through bowel ostomies, through fistula, drainage bags. Sometimes if patients have different, you know, if they have problems with their lungs and they have to take some fluid out, that's another way that water is lost in the body. Again, we have talked about diarrhea, vomiting, and, you know, if you have excessive oral secretions, there's patients that have constant mucosa. That's another way for an individual to have water loss. So, again, how much do you know, how much does a patient need a fluid replacement? Again, it's not only based on diagnosis, it's also based on weight. It's also based on age. Again, the more active, the more functions you have, the more need for hydration. If you tend to be bedbound, it doesn't mean that you don't need fluids, but it's not, the need is not as much as if it was an active person or somebody that was going through treatment. And then again, you know, that is one thing that needs to be adjusted based on treatment, based on diagnosis, and based on care. And that is one thing, unfortunately, that we tend to forget to ask the providers, how much fluid should I be taking and what kind of fluids? They talk about food, they talk about weight, they talked about foods to stay away if you take certain medications, but hydration is not addressed much. So I'm glad that Jackie asked me to talk about it, because it's something that we need to stay in tune. Again, you know, I already talked about, did I go backwards? Or is it a repeat of my ways to increase fluid consumption? Again, have water bottle accessible, something that won't bathe them as they're drinking, that will give them enough water, because again, some patients are picky about getting their clothes wet, or, you know, they have fear of choking. Another way to make water more appeasing, or for people to be enticed to drink it, is like Sarah mentioned, add lemon, add flavor, add ice cubes to it. Sometimes they have, this has worked in some patients that are kind of depressed. There's ice cubes that are plastic that you freeze, and just the different colors and shapes make it attractive for that individual to drink more fluids. Again, I recommend that you choose more water instead of the soda that I kept asking. And, you know, again, you can add lime or lemon. I do have, let me go back. I do have one of the things that, as a healthcare provider, how do you know if you are given with lab values besides symptoms or side effects, or that are clear to the eye? Like Sarah was talking about my skin, you know, my mouth, You can see your eyes. You can see if you have sunken cheeks. Those are ways that just by looking you can tell if a person is dehydrated or not. But another way that the home health staff can check if a person is dehydrated and or malnourished, but mainly dehydrated, is by looking at lab values. And some of the lab values that you would look at would be if that person has had a basic metabolic panel, and you look at the levels of sodium, potassium, chloride, and bicarbonate, and just by looking at the levels, if they're high or low, that can give you a signal that there's something going on. In regards to the urine, Sarah asked me the color of my urine. The higher the concentration, the color, the more dehydrated the person is. And again, if you look at the CBC, you look at the hematocrit and the hemoglobin. And again, not only with diabetic patients, but with any patient that is under stress, you would look at the glucose, the sugar level. If it's elevated, it can be a sign. If it's somebody that has never had issues with diabetes, it could be a sign of dehydration if the glucose levels are elevated. And then you look at the osmolality of the urine. You look at, you can do, if a person continues to have diarrhea, you do a stool culture to see what's going on, if that person has an infection, it has a virus, or what is being excreted through the urine in the bowel movement. So that is all I have for you guys in regards to hydration and malnutrition. So thank you for your attention. Do we have any questions or calls?
We do.
Oh.
Let's see, talking about urine, should urine be clear?
Again, urine, it depends on the individual, but the lighter the color, the more hydration it shows. I don't know how clear it should be, because I would think it's just the intensity of the color.
And what about medication? Does that affect the color of the urine even if you're properly hydrated?
Yes, there are certain medications, especially if you have a bacterial infection, there are certain medications that will affect not only the color, but the smell of the urine. Good question.
And there's another question about soup. And is soup considered a liquid when it's consumed as part of a meal?
It is, but then again, I caution if it's individuals that are watching their sodium intake. Soup is a liquid. So yes, you can count that as part of a fluid intake. But I caution giving soup, too many soups, because usually soups are very high in sodium. And if an individual is having fluid retention or heart issues, you don't want to elevate the sodium too much. Any other questions?
That's it for now.
All right. Well, if that's the case, thank you for your attention. And I guess we'll look forward to the next webcast.
Yes, thank you. Thank you so much, Julia. And it was a delight also to have Sarah with us today. And I would like to just mention today, as a matter of fact, came across the email. There was an article that is a white paper, actually, that is related to the role of nutrition in pressure ulcer management that has been written and published in the Advances in Skin and Wound Care, the Journal of Prevention and Healing. So it actually included the algorithm that you shared with us. So it's a very timely topic, and we do appreciate this. If you are planning to get the CEUs, of course, go back to the website for the details on that. We also have on-demand programs as well as some upcoming programs that you might be interested in. And please refer to the Alabama Training Network website there for the Alabama Department of Public Health. And thank you again for watching and tuning in, and we appreciate your participation.